1, 2, 3, go.
All right, hey, Dr. Dave here, Calabro Chiropractic and Wellness Center. What we're doing is I'm going to demonstrate a adjustment today. And I have Emily here. Emily is 18, 19?
18.
18 years old, recently graduated high school. And so she has a case that I thought was interesting. She had scoliosis, and she had spinal corrective surgery for scoliosis. We'll look at her x-ray in a little bit. But after the surgery, she had the surgery about 4 years ago, she started to develop other symptoms. So some of it was neck pain. About a year after the surgery, she started to develop neck pain and headaches, daily headaches, which resulted in her in taking over-the-counter medication multiple times a day to deal with them. I think excedrin, right?
Yeah.
That we would take excedrin. She was dealing with those for 3 years.
Yeah.
3 years of headaches daily. And then she also had sharp stabbing low back and hip pain. Mostly on the right side, but it could occur on both sides, but she was having low back pain, hip pain, flank pain, all in this area, all every day as well. And so sometimes she would walk and she'd get some zingers, and sometimes some sciatica-like symptoms. So she came in here and did an evaluation. We kind of showed that video on a different video. And now we're going to take a look at her x-ray. All right, so those are some of the background of what she came in presenting with. And so we're going to look here. Did you want to add anything or?
No.
No. So right here we're looking at her. We're actually looking at her from the back. So I do these 14 by 36 x-rays. It's a full spine x-ray. It's one shot from the front. It decreases exposure, so it's only one exposure instead of multiple overlapping exposures, number one. Two, it gives me a whole look at what the spine looks like. All right, so we're looking at her from behind as if she's facing the wall and we're looking behind her. This is her left shoulder, this is her right shoulder. Here are her surgical screws and the rods they put in to reduce the scoliosis. Now, I did see it before after. She showed me a picture of it. And it was significantly, she had a significant scoliosis. I don't remember the degrees off the top of my head. But she still has some curvature here as she goes up and curves here in her mid-back pretty big and then in her neck. So it didn't fully straighten it out, but it reduced it a lot. What's here now is that her left shoulder is higher than her right shoulder when she first came in. So this was elevated. There's a lot of muscle tension spasm here. Her head was kind of off to the right a little bit. Her hips, her left hip is higher than her right hip, so she has a pelvic tilt. So between the pelvic tilt, some of the curvature still here, shoulders being off, head being off, what that does is it stresses out the nervous system, the muscular system, which we demonstrated on scans that we did on her, computer scans. But you could also feel it. I mean, I could feel it as a trained chiropractor in her body. But here's the front view. Now we're looking at the side view. And you can see here again, the side view of the spine. Now, in the spine, there should be a curve to the neck. It should be curved up this way. She has what's referred to as a forward head carriage. She lost the curve in her neck. It's putting stress on the front part of her bones. She's starting to get the beginning of what's referred to as anterior spurring, some arthritic spurring. That's because that forms because the abnormal curve, there's stress on the front of the spine where it shouldn't be, and it's those bodies responding to that. So she's got a forward head carriage. She lost the curve in her neck. Her head is, spine is off to the right on this view. So that's putting a lot of stress in the upper portion of her neck, upper portion of her back, and that was creating her headaches. And her neck pain, and all the muscle tension. So then in here, she's supposed to have a curve in her mid-back, and there's no curve there, it's straight. She has an accentuated lower back curve. There's a little bit more here than there should be. The bottom portion that's not fused is angled a little bit more than it should. It's putting a lot of stress on this L5 disc, the lower back spine, causing a inflamed disc on this level. So she's got an irritated, inflamed, swollen disc, which is contributing to some of the sciatic pain she was experiencing in lower back pain. The other lower back pain, the flank pain, the hip pain had to do with the pelvic tilt and the rotation seen on here causing problem in her right side lower back. So you can see there's problems here in the spine. She's got these rods in which, you know, we're not going to be adjusting in these areas because there's nothing really you're going to be doing in that area. So we want to protect below in this area and above, because these areas are now taking up the slack for all in here. And so these were contributing to her pain and symptoms. So we're going to demonstrate an adjustment shortly. But what we will find out now is that after a bunch of months of care, your headaches are gone, pretty much. So her headaches are gone. You haven't taken any over-the-counter medicine in a long time.
Yeah.
So she has no more headaches, not taking any more over-the-counter medicine. Her general pain is pretty much gone. She'll get a random something here and there depending on what she does in her activities of daily living, just like anyone else. But in general, she has a completely different quality of life at this point. At 18, dealing with what she was dealing with, what she presented with, fast forward that to her 30s, 40s, 50s, 60s, like what quality of life would that have been down the road? And now it's a totally different experience, life expression, health expression, and she's living a better quality of life as a result of it. So we're going to do an adjustment, demonstrate what that is. Come on over here, Em. So a patient comes in, they typically start off sitting in this chair. I primarily practice a technique called Gonstead technique. There are times where I will do an offshoot and use other techniques or a different technique or incorporate it, but I typically use 98% of the time Gonstead technique, Clarence Gonstead, Gonstad. And there's a whole system of analysis of the spine related to Gonstead. So we use this heat reading instrument every visit. It helps me determine where there's stress in the spine, because when the spine misaligns, it gives off abnormal heat patterns. And so this helps hone in on the specific areas rather than putting someone on a table and just racking their spine up and down. Like in her case, you just can't do that, especially. So you want to hone in and become more specific with the adjustment. This helps me do that, in addition to some other, I feel for muscle spasm, tension, decreased mobility, and that's the analysis. We look at other things too, but that's a general idea. So typically I just run this up and down the spine. Sometimes the person has in a gown, but if they have loose fitting clothes. See, now I get a reading here, but that's a reading where she's got her surgical rods. So I might do some soft tissue work on there instead of a manual force in that area. And so I just look at this needle that's on the scope here, and it's showing some activity down near in her lower back at about L5 as the needle goes one way and comes back the other, right in that area. So typically what we would do is mark that with a skin marking pencil. That comes off, rubs right off, but that's an area that I want to feel. And then we just go up also the neck. Probably can't see this, but she's got some pressure up there too. So now after that, we feel. I want to feel, compare. I'm finding pressure in her upper neck. I want to feel range of motion. And what I'm feeling for is comparing both sides. When I turn this way, I'm comparing her upper neck on the right. I feel those segments separate. When I'm on the left, I don't feel those separate. So she's got a stuck upper neck on the left side. Now her rods go from T3 to L3, and so a lot of times she has a T2 here that's involved, and I feel a little bit of that. Then I would go down to where I put the mark lower back, and I'd feel what's going on with the structures here. I'd check out sacroiliac joints, right side, left side. Feels like she has left side pelvic that's pelvis that's stuck. Now when she came in, her left shoulder initially was elevated like this from muscle tension spasm, and now it's significantly reduced. It's down like a lot. Sometimes with Emily I would use muscle stimulation. I'd put it on her trap muscles, her left trap and rhomboid, to relax this. It depends. I don't have a cookbook for patients that walk in. I don't do the same thing on everybody. It really is case dependent. That's what I like about this technique. You have the technology, you have the heat reading instrument, you have the x-ray, you have the palpation skills, and you get and plus what the patient says, you get a whole idea of what is going on with the individual, and it allows you to tailor care a little more specifically. So from here, we're going to go to this table. And Emily gets excited because this is like a very exciting ride for her. No, I'm kidding. And so what happens is, patient steps up on here and the table slowly goes down. Now on this card, I have written down Emily's x-ray information, what are called her listings that I got off the x-ray. It tells me what each segment is doing, how it's tilted, how it's rotated, and I use this as a guide as to what side and what segment I'm adjusting. Again, tailoring it, making it more specific. I may scooch her up a little bit. That word scooch. So what I found with Emily is sometimes because of her rods here, that her pelvis actually adjusts really easy in the face down position. A lot of times I adjust pelvis on a bench, on the sideline bench, and I might do that on her right side. But a lot of times I really just, she's easy to adjust. You get on a segment and you just push. Now, I don't know if you heard that pop, but I felt it and she felt it. So she had a right sacroiliac joint. I think I was feeling left too when I got some movement out of there. A lot of times Emily has a rotated pelvis, so I find that sometimes it's one or the other, sometimes it's both, depends on what she presents with that day. Normally, again, for other patients in the mid-back, then you would adjust whatever area you find laying on this table face down. I'll just get a feel for her T2 up here to see what kind of tension is in it. Other times I check knees, I check feet, adjust those if necessary. We're going to go to this table next. This table, Emily is going to lay on her side and face me, her shoulder here, her head here. Now, you have to be aware of, she's got this hardware throughout her spine, so you have to be aware of that when you position a person. So with her, I will go a little lighter. She's tiny, she's flexible. I mean, when she turns sideways, you can barely see her. She's so thin. No, I'm just kidding. But in this, I'm going to get right on her lower back. Again, addressing this right sacroiliac joint. I'm going to kind of stretch her out like a rubber band. Then I'm going to lightly push. And it did, we look for or listen for what's referred to as a cavitation, the crack. The crack, you don't need to have that to have an adjustment. It all depends on, at the end, did you adjust something and create more mobility to it, and what you were finding, did you correct that? It did have a cavitation. The cavitation, the crack sound, a lot of people put a lot of weight on the sound. All it is a gas release. It's something that freaks people out, yet it's just a gas release. So after here, we're going to go back to this chair. So the interesting thing about Gonstead technique is that you adjust people in different tables. Typically the neck is adjusted in a sitting position. Mid-back is typically adjusted on that. on the high-low table. You could adjust really anything from neck all the way down to pelvis and everything on there. And then the side lying table, side posture, is done for lower back, anywhere in the lumbar spine, sacroiliac joints. So sometimes when you start adjusting these other areas, you start to feel things different because what's going on in the lower body actually affects the upper body. So all the tension I was feeling on the left side of her has gone down a lot. And I haven't even touched her neck yet. So what you're going to see me do, I'm going to be adjusting her upper neck, her C1 on the right side. So you're going to feel me bring her head over a little bit, and then you're going to feel me push this way. And again, you hear the cavitation, the cracking noise. All that is gases being released. Now for Emily, I can also check her shoulders and adjust shoulders. Sometimes I do the sitting, sometimes I do it laying down. I want to get her scapula moving, especially. And then we'll check wrists and elbows. It doesn't look like she's getting tortured too much, right? I mean, and that's basically it. That's chiropractic adjustment. Thanks for tuning in, and we'll catch you on another video.